This is part 2 of a video on myofascial release assessment. I'm Walt Fritz from the Foundations and Myofascial Release Seminars, and I'm here at Oakworks today. After sitting, I'm going to position my patient in supine. I have a sequence that I tend to follow. It certainly isn't the sequence that every therapist has to follow, but it's one that's worked for me over the past 20 years, and it allows me to collect enough information from toes to head that allows me to make some good treatment decisions. Where I typically start is down here at the feet. I want to make sure that, first of all, she's positioned in midline on the table with her feet in line with her torso. And if they're not, I'm going to correct it. I may ask her to lift her buttocks up in the air and come on back down if she's not. First, I'm going to just gently take hold of her heels and just traction a little bit. This gives me some information on flexibility or lack of flexibility up the posterior legs, into the hips, into the pelvis and low back. It also gives her an idea, or at least a beginning of an idea, what it is that I'm doing, what kind of pressures I'm using. She'll find pretty quickly that I don't go very deep in terms of my pressure. None of this work should be painful. Now I'm going to come in and I am going to do a leg length measurements. Some therapists do this in prone. I prefer supine. My thumbs are positioned just under the medial malleoli, and I'm just looking down and comparing length. Now she has a right leg that's about 3/8 to a ½ inch longer. If I wanted to get a tape measure out, I could measure it, but you can also eyeball these pretty accurately. Now, before we started, Molly had related to me that one of the things that was bothering her was her knee. She's had multiple knee surgeries and still gets some knee pain. She also said earlier on that she did have some issues with an acute neck problem a few days back that's resolved itself relatively well. And she didn't tell me this, but we found she's got a little bit of right torso pain or right low back pain when we did that rotation. So where I'm going to come next is I'm going to do just a brief assessment on kneecap play. Now, if you remember when you were a kid and you went and wiggled your kneecap, it felt like you could just push it off to one side or another and totally dislocate it. And believe it or not, as an adult, it would be great if we still felt that, but most of us don't. Now, Molly has an increased amount, or excessive, I would call it, interior play, and both of the kneecaps don't like going to the lateral direction very well. She's got a little bit of a clicking in the right kneecap when we go side to side, and up and down, you know, not that bad. And the camera can't pick it up, but she's got lots of scar tissue down in here, both left, right, above and below the knee. Next, I want to get an idea of the quality of how the flexibility of the quadriceps is. So instead of just doing a light palpation, what I'm going to do is go in a little deeper here. And you'll notice I'm using my body weight a bit here, and I'm looking to feel for those lumps. Do you feel that? Mm-hmm. It feels like there's a hot dog under her skin when I roll back and forth. What that represents is essentially scarred down quadriceps that's not functioning the way it should. It doesn't have either the flexibility or the reverse of flexibility is contractibility, the strength. So when I feel this sort of lumpy hot dog in somebody's knee, I know it's something that I at some point want to come in and address. And then the general tone of the thigh, of the quadricep, is she's got a fair amount of denseness. Now, I'm going to come back in. I am going to eyeball the ASISs again, and they match exactly what I found when we had her standing up. Now, Molly, I'm going to ask you to bend both knees for me, please. Spread your feet apart, about shoulder width. Good. Now, this is an orthopedic test as well as a muscle energy technique to check the integrity of the pubic joint, of the pubic symphysis. So I'm going to ask you to, I'm going to put my forearm in between your knees here. I want you to squeeze your knees together as hard as you can. And you hear that little click?
Oh, yes.
Yeah. So you have that little click that often happens. It's a muscle energy technique, so it's going to mobilize the pubic symphysis back into place. But in addition to the actual little bit of treatment there, I was assessing how much strength she had. The strength in that technique has nothing to do with the muscle strength of her leg adductors. It's got everything to do with how well seated the pubic joint is. And in Molly's case, it was probably a little below 50%. Pelvis is a little out of kilter there. Okay, we're going to have you straighten your legs out. Next, I'm going to double check what we found in standing. I'm going to palpate the ASISs, and it was just as we found when she was standing. The left side is low, right side is high. Now I'm going to come in, is it okay if I lift this up? I'm going to do a little bit of gentle palpation into the area of both of the psoas, which if you look, here's the umbilicus right here. The psoas run an inch or two just lateral to the umbilicus. They start drifting outward a bit. They cross the pelvis right here, and they insert at the lesser trochanter. Very important muscle groups of the low back because it attaches at the transverse process of L1 down to L5. So what I'm going to do is with my hands just to the side of the umbilicus by about an inch, I'm going to gently and slowly work my way in until I feel that first barrier, that first layer of resistance. And I, as the therapist, I'm looking for areas of denseness, of tightness, of ropiness, of leatheriness. There's something right there. Do you feel that spot? That hurts, yeah. Molly, how much pressure am I using?
Not much.
Not much? Good. You really don't want to be aggressive at all with this technique. You're going to lose your patients very quickly. And I can trace, no, not much in there. That doesn't feel bad. The line of the psoas. If I wanted to, I could follow it all the way down, cross the pelvis into the region of the lesser trochanter, but I'm going to come over here on her left side and see if I can feel something. Now, there's a little something right there.
That hurts.
That hurts?
It hurts in my back.
So you feel it referring into your back. Which side of your back?
My left.
Okay. Is that a familiar sensation to you?
No.
No. Okay. And she has a few areas that to me feel tighter, and there's another spot there. Do you feel that?
Yeah. That hurts.
Is that local or anywhere else?
Local.
Local. Okay. Now, if Molly had any surgical incisions of any kind, be it a laparoscopy scar through the belly button, C-section, hysterectomy, appendectomy scar, I would certainly go in and I would palpate, I would evaluate that scar in the exact same way that we did. I'm going to trace that scar with my fingers and just gently press in. I'm looking myself for areas of tightness, density. I'm also looking for reactions from her. But since she has no abdominal scars, we're just going to keep moving up. Actually, I need to lift this up. That's fine. And I'm going to reverse directions here, and we're going to check her respiratory diaphragm. I'm going to gently press down toward the table and down toward her feet, and I'm checking for tightness. And I'm also looking for reaction.
I'm good.
You're good?
Yep.
Nothing at all. Okay. It's not uncommon when you come in here for your client to feel just a little short of breath, and not uncommon at all to feel reflux or that acid indigestion feeling. Now, another area I always like to check is down at the lower part of the abdomen. And is it okay if I lower this just a hair? Okay. I'm going to put a hand right about an inch or two above her pubic joint. I'm going to gently press down toward the table and up toward her head. Here, I'm getting a more three-dimensional view, a more three-dimensional feel of what's going on in her pelvis, in her abdomen, as well as the anterior portion of her lumbar spine. Now, I'm not feeling a whole lot in here. A little bit of tightness right there, but other than that, not bad. Yeah. If she had a lot of scar tissue or a lot of issues with back pain, I can expect to find a lot more than that. I'm going to move up. I would certainly do this on both sides. I want to do a gentle arm traction. When you traction the arm, it should be as if the arm was attached to the shoulder. Everything was one nice big elastic band where it all gives without any kinks. Now, I kind of hit a stop right up at the shoulder. Not a lot of flexibility past her shoulder. The whole upper shoulder trap region up to the neck all acts as one unit. And got a fair amount of tightness around your wrist too. You feel it?
Very old shoulder injury.
You have an old shoulder injury. To this side?
Yeah, just
okay.
this one.
All right. Next, we're going to check her for cervical flexion. To do this, I'm just going to lift right up. And you'll notice I have the heels of my hand under her occiput. All I'm doing here is checking flexibility. If somebody's very tight through the posterior thoracic or cervical spine, they're going to be stood up here like I'm holding a board. But Molly's got a fair amount of flexion available. You can see that, a nice curve in the cervical and thoracic spine. I'll slowly let her down. And I'm going to check extension. How I check extension is with my fingertips, I come under her upper thoracic spine and I start working my way up, checking individual segments to see what kind of extension she's got there. And if you hit areas where she's not moving, you're going to feel it pretty quickly. I also want to empower my client that they need to let me know what's going on. Like, Molly, is that a familiar spot right there?
Yes.
Yeah. Right at about T1, C7 on the left, she's got a fair amount of tightness. It feels like the first thoracic rib is pretty stuck right there.
Mm-hmm.
So we'll keep going. Those are types of things I'd make notes of and come back during treatment if it applied to why Molly was coming to me. And finally, when we get up to C1, go ahead and relax. I'm going to extend my fingertips, stand her right up in the suboccipital space right at C1. And what do you feel there?
Not much.
Just pressure,
Feels good.
right?
Mm-hmm.
A lot of times this will be very uncomfortable, but it'll also reproduce the beginnings of familiar headaches or migraines for folks. So it's an important area, the suboccipital region, to both evaluate and treat. I'm going to let you down. We're going to gently test rotation. If they've had a lot of physical manipulation or adjustments from a chiropractor, I like to let them know I'm not going to do any sudden quick movements here so they can feel a little safer. Now, watch what happens to her left shoulder when we turn to the right. That left shoulder just begins to pick right up there at end range. And much less pronounced with her right shoulder when we go to the left. So she does have a little bit more tightness at the extreme of right rotation, but a lot of tightness in through here. And we can also check side bend. No problem at all there. Okay. Next, I position my client in prone, and I'm going to first check quadricep length. Now, most of the times when you start doing this, your patient will start to help you, and you'll be able to tell because their hamstring will contract. I want to do the work here, so go ahead and soften, let me do the work. And what I'm doing here is I'm taking her to a very subtle first barrier. I'm checking to see where that first barrier is. In her case, it's about 105, 110 degrees. That's fair. It's not great, but what do you feel right there, Molly?
Knee pain?
So you feel your knee pain. Okay.
Mm-hmm.
Is that a familiar pain?
Yes.
Okay. So there's a fair chance that at least some of her knee pain could be tied into this quadricep tightness. We found it when we were in the front, and now we're confirming it in the back. And let's just compare. And first barrier, it's a little tighter on that side, probably 100, 105 degrees. And what do you feel on this side?
Nothing really.
Nothing. This feels like just a stretch.
Mm-hmm.
Do you feel the stretch just in your thigh, or do you feel it anywhere else?
No, just in the thigh.
Okay.
Right
Very
there.
common for somebody to feel it up in their low back as well. And to me, that brings in the quality of the quads, that quads are important when we're treating low back pain. Because of their attachment at the pelvis, they can tip that pelvis forward and create some additional strain on the lumbar region. Now, you may have noticed when I had Molly supine, I didn't check her hamstrings, and that is one of my habits. I typically pay no attention to hamstrings, even if someone's coming in with hamstring pain, because I find in the myofascial release approach that I utilize, you really don't have to end up treating the hamstrings very often. If the pelvis is tipped forward, you create a situation where there's already an overstretch of the hamstrings because of their attachment at the ischial tuberosity. If the pelvis is tipped forward, that hamstring is already screaming a little bit. So it could be other areas. It could be this area up in here. It could be the psoas that's pulling too tight, tipping the pelvis forward. All those things I need to take a look at. If the hamstring needs some work at the end, I will address it, but I typically don't start with that. Now, I'm going to again confirm what I found with the PSISs, and it's the same. If I need to, I can do a little bit of palpation in through the sacroiliac region, often down into the piriformis region. Any tenderness there or not bad? Yeah. And both sides don't feel bad. You know, in this area, a lot of your patients will just jump off the table. Piriformis is another muscle group that I seldom treat directly. I was taught a lot of direct, aggressive work for piriformis where you get in there with the elbow and you work it like that, get them on the foam roller and have them do some aggressive, painful work. I don't find it's necessary. If we can free up in through here through a number of different techniques we utilize in the Foundations approach, you really don't have to go through that painful type of treatment. Now, I'm also going to poke around here at QL. She's got nice flexibility here. Now, I hope the camera can pick this up. As Molly lies here, if you take a look at her landscape, the right side of her torso, of her rib cage, is flatter toward the table than the left side. So she's got that asymmetry within her rib cage. Very typical in our clientele. In fact, it's atypical for somebody not to have some rib asymmetries. It's atypical for them not to have a very minor spinal curvature. But again, we're taking note of this. Does this come into play with any of the things we're treating Molly for? And I may just do a little bit of a gentle rib spring. And what do you feel right there?
A little pain.
Little pain. So exactly that spot that you can see humping up, actually, I can feel there's tightness, there's density in through some of those ribs, and she's feeling a little bit of discomfort there.